Good day to everybody. Here are my disclosures, and here are my learning objectives. You remember the criteria for antiphospholipid syndrome. Here was the first major iteration. It seems quite simple, doesn't it? Vascular thrombosis, pregnancy morbidity, in the setting of lupus anticoagulant or anticardiolipin, positive twice over a 6-week period of time. But then you remember it was revised, and anti-beta 2 was added, and now the criteria said you had to be repeatedly positive over a 3-month period of time. So I guess I'm here to tell you that these kinds of rules never seem to work in lupus. First of all, we're rheumatologists, and so we deal with a lot of the inflammatory, non-thrombotic manifestations of antiphospholipid antibodies, as you see here. And one of the most frequent that we see is, of course, this rash, livido. But this particular livido is called livido racemosa because it's so coarse and thick. It's obviously, clotting forming in larger venules. This is highly associated with later thrombotic risk. It turns out that not all the antiphospholipid antibodies are created equal, even though you would think they were based on those classification criteria. So the one that's most important, the bad actor, is the lupus anticoagulant. It's the major risk factor, not just for thrombosis, but for adverse pregnancy outcomes as well. There are 3 steps in confirming a lupus anticoagulant: the screening time, the mixing study, and the confirmatory step. Now it is possible to do lupus anticoagulant testing in patients who are on DOACs if the laboratory you use has set up DOAC stop. One of the problems we face, though, in lupus is that antiphospholipid antibodies fluctuate. Now, you're not surprised. Anti-DNA fluctuates, complement fluctuates. This is lupus. But if we look overall in our Hopkins cohort, antiphospholipid antibodies are quite frequent over the lifetime of the patient. But I want to show you how to interpret these tests when you get them back. So here's one of my patients who only has a confirmed lupus anticoagulant at one of these 6 visits. On the top line, you see the screening time, which is always elevated. But then you remember the next step is the mixing study. And some lupus anticoagulants correct on a 1-to-1 mix. It's much less likely, though, that a lupus anticoagulant will correct on a 4-to-1 mix. But only at one of these visits does the patient make it all the way through with a positive RBVT confirmed, meaning a confirmed lupus anticoagulant. Here's another example, a patient who's positive 50% of her visits. Now you're used to this format. Always has the screening time elevated, often corrects on a 1-to-1 mix, less likely to correct on a 4-to-1 mix, and 3 different times has the confirmed test positive, so a confirmed lupus anticoagulant. Now, if you have memorized that 3-month rule, you'll notice that we never would have picked this up if we based it on criteria, because even the 2 visits in a row where she was positive were more than 3 months apart. So in real life of lupus patients, it's very rare for a patient to have a lupus anticoagulant repetitively positive over 3 months. Here is all the data from our cohort, and you can see most patients who are positive for either high titer anticardiolipin or the lupus anticoagulant are positive less than 25% of their visits. So do we care? Well, of course we care, because those patients who are intermittently positive still have an increased risk of later thrombosis. Even those who are positive less than 25% of the time have a 50% increase in their relative risk, a p-value of 0.05. But once you're positive more than 25% of the visits, your relative risk is 3-fold increase, very statistically significant. Now, another problem with those classification criteria is that lupus patients love to make IgA antibodies. And in fact, the IgA isotypes are the most common antiphospholipid ones. Do they matter? Well, yes, they do matter. So here you see for anti-beta 2 for IgA, a 1.9 odds ratio of having a venous thrombosis that's very statistically significant. Now, it's not as much of a risk as IgG, but it certainly is a statistically significant risk. The IgM isotypes are actually included in the classification criteria. But again, doesn't make sense for lupus because IgM anticoagulant is not associated with thrombosis over the lifetime of the patient. You see the rate ratio stays around 1. Now, there are non-criteria assays for antiphospholipid antibodies, and I wanted to mention to you one that actually is useful, antiphosphatidylserine prothrombin, or anti-PSPT. It's done on serum, you don't need blood, and it is highly associated with the lupus anticoagulant. So if you have a patient where you can't correct for the warfarin or the low molecular weight heparin or the DOAC, you could order this. It's like a substitute for a lupus anticoagulant. But in lupus, thrombosis is not just an antiphospholipid story. Now, of course, there's some other factors we never want to forget, like if the person's nephrotic or if she's on oral contraceptive pills. But I wanted to introduce you to the field that's called immunothrombosis. Complement is involved in thrombosis. So no surprise, right, that our lupus patients are hypercoagulable. And there's crosstalk in both directions. So complement split products can activate platelets and start the coagulation cascades because they increase tissue factor. But it can go the other way. Plasmin can actually activate C5. Now, the importance of these complement issues has been recognized in hematology for some time. They call these complementopathies when a patient has an acquired mutation in one of the genes that regulates the complement cascade. And examples are paroxysmal nocturnal hemoglobinuria and atypical HUS. And the HELP syndrome, by the way, is just atypical HUS occurring during pregnancy. So remember that you could have mutations that work in two different directions. You could have loss of function mutations in the inhibitory genes of the complement regulatory pathways, or gain of function mutations in the activating genes. And both things happen. And what's very important is that this now turns out to explain CAPS. So CAPS occurs in patients who have antiphospholipid antibodies plus have one of these acquired mutations in their complement regulatory pathways. Now, how often does this happen? These are the data presented by Dr. Chaturvedi. She works in Rob Brodsky's group at Hopkins, and they presented at the ASH meeting last year their data that show that 60% of patients with catastrophic APS have one of these complement regulatory gene mutations. This is just about the same, if not a little bit higher, than atypical hemolytic uremic syndrome. So they have figured out CAPS for us. And now you can understand why if you encounter a CAPS patient and you have access to eculizumab, the monoclonal that blocks C5a, this would be your ideal treatment. Now, what about in our lupus patients? Can we predict the risk of thrombosis? And the answer is, antiphospholipid antibodies alone are not the best. I'll show you. We always have to include, any other factors the patient has. But I think where we've been missing the boat is we have not been including immunothrombosis in our risk formula. So this is what I reported way back in 2002. If a patient at the time of her diagnosis has the lupus anticoagulant, over the next 20 years, she has a 50% chance of having a venous thrombosis. I didn't even include arterial in this particular analysis. This is over 20 years. So of course, at time 0, we'd like to start her on prophylactic therapy to prevent this, but that prophylactic therapy has to be very safe because we're going to be giving it for many decades, aren't we? So if you look at how others approach the risk of thrombosis in people with antiphospholipid antibodies, They deal mostly in primary, so they're not including a lot of lupus patients in their calculations. And this is a very catchy term. Triple positivity comes from Professor Pango in Italy. So what his group looked at was if you had all three of the criteria antiphospholipid antibodies, you're more likely to have the same confirmed 3 months later. And so he likes to think that triple positivity is the best way to predict who's at high risk. But it turns out that doesn't work. In lupus, we showed it didn't work because in lupus, really all the risk is explained by the lupus anticoagulant. So you don't increase your risk if you have anticardiolipin and anti-beta 2. In the PROMISE pregnancy study, which included not just lupus patients but primary patients, only the lupus anticoagulant explained the risk of adverse pregnancy outcomes. Anticardiolipin and anti-beta 2 did not. So where should we go? Well, you could go really complicated. So here is the Japanese risk equation for thrombosis. And what they decided to do was, well, let's just measure every single antiphospholipid antibody assay there is. Now, nobody in their right mind has all these things set up in their laboratory, and we can't afford to do this in real life. So, this is just an interesting approach, but not practical. You may have heard of GAPS, which stands for the Global Antiphospholipid Score. This took a different approach. By the way, they included a non-criteria assay, that anti-PSPT, but they decided to include 2 risk factors for arterial thrombosis. I've always thought this was strange because in APS, usually there's just as much venous as arterial thrombosis, so why not include some risk factors for venous thrombosis, right? Like sedentary lifestyle or oral contraceptives or obesity or something. But this one really isn't used widely either. So what should we do? Well, I've introduced this term immunothrombosis, and now I want to let you know that platelets are also involved. Platelets are intimately involved in these coagulation and complement pathways. So when you think of immunothrombosis, I now want you to think of 3 different things: lupus anticoagulant, activated platelets, and complement. Now, the first to recognize how important this was in lupus was actually the Pittsburgh group that showed that C4D, a complement split product bound to platelets, was associated with both venous and arterial thrombosis in lupus patients. Those are very respectable p-values. They also showed that this was true in a non-lupus stroke population as well. So even though we think of immunothrombosis in lupus, and by the way, we think of it in COVID too, it's probably true in the general population. So I want to show you what this looks like in a risk equation. But here we're just going to start out by looking at C4D bound to platelets. Now this is a research assay. It's not set up in your laboratory. This is to prove the point. The way this slide is oriented is any thrombosis on the left, venous thrombosis in the middle, arterial thrombosis on the right. And the different gradations are how much platelet C4D the person has. And so what you're going to see is that the more you have, the greater your risk. And yes, it does work a little bit better for venous than arterial thrombosis, but it works for both. So now we're going to put it all together. So here's the Hopkins risk equation for thrombosis, and it includes low C3, lupus anticoagulant, and the platelets bound to C4D. Same orientation, any thrombosis, venous, and arterial. And you can see if you just have one risk factor, your risk of having a thrombotic event in the last 5 years hasn't gone up very much. And as you have 2, it goes up more. And oh my God, if you have all 3, you're at like 75% chance of having had a thrombotic event in the last 5 years. So this is quite steep, isn't it? 1, 2, 3. You can see it does work better for venous, but it does work for arterial. It's highly statistically significant. So now let's go back to Professor Pango. Does this work better than triple positivity? And the answer is absolutely. If you have 2 or 3, it is statistically superior. And here it is graphically, if you like looking at receiver operator curves. Now, how do we treat antiphospholipid antibodies? So first, let's talk about prophylactic treatment, because we're able to do this in our lupus patients, aren't we? Because we know they have the antiphospholipid antibody. We don't have to wait for something awful to happen to them. We can actually discuss prophylactic treatment. And there are 4 players in the prophylactic armamentarium. Now let's start out with low-dose aspirin. You know, low-dose aspirin never had a successful clinical trial in APS. So 2 negative trials. But in a meta-analysis, Dr. Arnaud did show that low-dose aspirin likely has some benefit, as we would expect, right? Because it would work on platelets. We have much better data for hydroxychloroquine, not a randomized clinical trial. That probably wouldn't be ethical, but you can see in the cross-sectional and longitudinal studies how use of hydroxychloroquine does reduce thrombosis risk, probably by about 50%. Now, I'm a firm believer in hydroxychloroquine blood levels. You probably already know that. And so what we have published is that your hydroxychloroquine blood level needs to be 1,000 for that patient to have that anti-thrombotic benefit. What about statins? Well, theoretically, these sound like a good choice because they affect the tissue factor, part 2, and neutrophil pathways. And we know that these are the pathways that lead to neutrophil activation, which is part of the antiphospholipid pathway. Both simvastatin and pravastatin have been proven to decrease tissue factor and part 2 expression. But what kind of clinical non-test tube data do we have? Well, we have studies in the general population like the Jupiter trial. Remember, that was one of the clinical trials of a powerful statin, and it did show a reduction in venous thrombosis. So we do think that this is real. But after hydroxychloroquine, which is my first choice for prophylactic therapy, my second favorite is vitamin D. We have so much data on vitamin D. First of all, in the test tube, it does inhibit expression of tissue factor. We know that vitamin D deficiency is increased in those with antiphospholipid syndrome and in those who actually have a thrombotic event. And outside of APS, there's even a randomized clinical trial in cancer showing that vitamin D supplementation reduces thrombosis. So I think quite powerful data. So my favorite prophylactic regimen is hydroxychloroquine and vitamin D. But what about in pregnancy? What do we do in pregnancy? Well, you remember that the favorite regimen is low dose, low molecular weight heparin and low dose aspirin. But, you know, the clinical trials are kind of a mess. By the way, they rarely included anybody with lupus. But the difference between heparin and low-dose aspirin and low-dose aspirin alone hasn't been overwhelming. And part of the problem is they really concentrated more on early first trimester losses, which are probably less likely to be truly causally associated with antiphospholipid antibodies. But even if you do low molecular weight heparin and aspirin together, you know, you only get a successful pregnancy about 75% of the time. So if we look at downstream, what happens after you have an antiphospholipid antibody, one of the next steps is TNF is active. And so Ware Branch and Jane Salmon were brave enough to start this trial, the IMPACT trial, looking at an anti-TNF that doesn't cross the placenta because it's pegylated. Now, those of you who have really studied your anti-TNFs know in rheumatoid arthritis, they can actually induce antiphospholipid antibodies. So, you know, do you have to be really brave to do this? Well, this is not done by itself. These patients are also going to be on heparin and low-dose aspirin. We need to have results. Now I want to turn to catastrophic APS because that's one of the most devastating things with a mortality of 50%. And triple therapy has been the rule for such a long time. So that's heparin, intravenous steroids, and plasma exchange. If you can't plasma exchange, then you give intravenous immunoglobulin. But obviously we have to do better because, you know, 50% mortality, that's awful. So rituximab does have benefit in case series, and I've personally rescued many patients using rituximab. But as we discussed, if you can get access to it, remember how expensive it is, you would want to use eculizumab, the anti-C5a monoclonal. And what do we do after someone has had a thrombotic event? Well, warfarin is the rule. And you'll remember these two clinical trials, both of which showed that an INR of 2 to 3 is sufficient. You don't have to get an INR of 3 or higher. And if you do aim higher, of course, there's an increase in bleeding risk. So an INR of 2 to 3. But the big question has been, can we use DOACs? And the answer is no. In particular, I want to draw your attention to the two clinical trials, apixaban and rivaroxaban, which showed that patients with APS randomized to a DOAC had an increase in arterial thrombosis, myocardial infarction, and stroke. So no, don't turn to a DOAC. So you're going to say, well, what if I can't keep the INR therapeutic? What am I to do? Well, I think my first choice would be in that patient to keep them on low molecular weight heparin every day. Now, yes, in a young woman, you might have the risk of osteopenia, but you can check for that. You can do bone density scans. A DOAC would be like, my bottom of the basement, last resort choice, because it's insufficient. Now, a hugely important question is, remember, the antibodies fluctuate in lupus patients. So what if the patient has had every antiphospholipid antibody assay negative for a year and a half or 2 years or whatever? Can we stop their warfarin? Well, this case series really worried me. Look at the recurrence rate in their lupus patients in this case series. And I've personally seen disasters. So, the party line is this is lifelong anticoagulation. But some patients really want to stop, or they've had a bleeding complication and you want to stop. So is there any new literature that might help you make a decision? And the answer is yes. But as with any new literature, sometimes it raises as many questions as it answers. So here's a very important study from Dr. Kiran. So this is looking at whether D-dimers might help you figure out whether it's safe to stop anticoagulation. And their view was yes in women, not in men. Now, of course, this isn't a lupus study, so it's my job to tell you that in lupus, D-dimers can be up just from activity of lupus. So I thought this might be something you'd want to look at, but I'm not ready to hang my hat on it. But here's something even more important. This is from Tom Ortel, a hematologist who's been interested in antiphospholipid antibodies for many decades. And this is a meta-analysis. It was hard for him to find enough articles of high quality in which to do the meta-analysis. And what he's doing is he's comparing treatments for venous and arterial thrombosis in terms of the recurrent thrombosis risk. And what you see, very surprisingly, is anticoagulation seems to do equally well as antiplatelet drugs. Boy, that's weird, because we've been preaching for years. When someone has had a thrombotic event, they get warfarin. But the reason I'm bringing this up now is, what if you did want to stop anticoagulation in a person who'd had arterial thrombosis? Well, this suggests that maybe you could start, maybe double antiplatelet therapy, and you might not be losing very much. But this is not a randomized clinical trial. This is a meta-analysis. So again, please take it with a grain of salt. So I want to thank you very much for your attention.